Good morning, everyone. For the sake of staying on time, I guess we'll go ahead and get started. It's 10:45. So, to introduce myself, my name is Dr. Vince Ma. I'm a medical oncologist like Dr. Albertini. I primarily focus on melanoma, but I also see advanced stages of skin cancer. And so today, I have the pleasure of being able to talk about some of the exciting clinical trials and studies that we have here at UW Carbone, specifically with the aim to improve outcomes of advanced stage or metastatic melanoma. So I'd like to just kind of mention a few disclosures as an advisory board position, as well as some of the research support that I have from industry. And so, as Dr. Albertini mentioned, in his lecture, we have a wide variety of different FDA-approved medicines to treat stage 4 melanoma. And as you can see here, really since 1998, there really wasn't much in terms of development for medicines to treat the disease. It really wasn't until 2011 where we've now seen an explosion of different therapy options that we have now available to treat the disease. And so I really want an opportunity to kind of highlight specifically the drugs and kind of understand what these drugs are. And so what's highlighted in teal are essentially your newer immunotherapy drugs. And the newer immunotherapy agents or immune checkpoint inhibitors, as we also call them, are generally speaking drugs that we can generally use for nearly or most stage 4 melanoma patients. Now, in contrast to that, we also have the pink labeled agents, which are your targeted therapy agents. And so these are really applicable or frequently used or can be used for patients who have what we call a BRAF mutation, where their melanoma has a specific mutation or a BRAF mutation. And that occurs in about 50% of the population. And so really since 2011, we've really only had two major classes of therapies. And so as a medical oncologist, we're kind of stuck with the role of sort of deciding between which two classes to use, and of those classes, what agent to use in the first line setting. And so the thing I want to mention is that, melanoma death rates here in the United States was fairly stable. And it really wasn't until, as you can see on the figure there, 2011, where we're finally seeing a decline in the annual death rates of melanoma here in the US. And a lot of that can definitely be attributed to the advancements and the new medicines that we have nowadays to treat stage 4 melanoma, which, as you may know, stage 4 melanoma being a very deadly stage, a part of melanoma. Now, here's the thing, especially with regards to immunotherapy, which is commonly what we use in medical practice to treat our patients. So I'll be mostly focusing on immunotherapy. But the thing about immunotherapy is that not everyone benefits from treatment. And so what I have listed here on the table is that, the percentage rates or the chances of actually responding to different immunotherapy agents. And so you can see labeled up there that the use of combination or two drug immunotherapy tends to have a slightly better response rate than, say, using one single agent of immunotherapy. Now, that comes down to a few problems, particularly with the current treatment landscape for melanoma. And the issues that we face as medical oncologists is that we know that there's a large proportion of melanoma patients, stage 4 melanoma patients, that don't respond to therapy. And to be honest, we are still developing newer ways to identify who is likely to benefit and who is not. And what we also know about immunotherapy is that the tumor, the same melanoma tumor that exists in the body, can respond differently to immunotherapy based on the location. And so, for example, what we historically know is that melanoma that originates or spreads, to the brain or the liver tends to not respond to immunotherapy as well as compared to areas like the lung or the lymph node. And so these are areas that we're still trying to understand a lot more as to why that occurs. Now, as a medical oncologist, when we see our stage 4 melanoma patients and start them on systemic or medicines to treat their disease, how do we frequently assess their response to treatment? And so we have a wide variety of imaging modalities that we frequently use. And so what I have listed up here are some of the most common ones that we typically use to actually assess a patient's response to treatment. And these include like MRI, a CT scan, or a PET CT scan. Now, when it comes to imaging, how frequent, how often do we typically do this? And so in the stage 4 setting, when we're treating our patients, we generally speaking do not perform these imaging until around 9 to 12 weeks after therapy. And that's a problemsome area, if you can imagine, which is that, for a significant number of patients who don't respond to therapy, they may be getting therapy unnecessarily and not responding to it. And as a provider, we don't know that until about 2 to 3 months later. So the question arises is, can we find a way to evaluate response even earlier so that we can potentially, as a provider, make treatment changes even sooner? And so I have here illustrated an example of what a PET-CT looks like. And so we are now in the process of opening a new study here at the University of Wisconsin, primarily looking at the role of using a PET-CT early in the course of therapy to actually identify if patients are responding to treatment even earlier so that we can make treatment changes even sooner. So why a PET-CT, amongst all the imaging modalities? And so we use a PET-CT because it really provides us the ability to get a global assessment of the patient's tumor status. We can actually assess where the cancer is located. We can see the size of the tumor. And the nice thing about PET scan is that we can actually assess the metabolic activity of the tumor as well. So it actually gives us quite a bit of information that we can use as providers to kind of assess how a patient's doing well with treatment. And so one of the studies that we're planning to open is where we're looking at the role of doing a PET-CT much, much sooner than that 9 to 12 week period, and hoping to do it at around a 3 to 4 week period. So what is the potential goals of this study, right? One of the major goals is to be able to inform us as providers early on in the therapy course to see if a patient is actually benefiting from treatment. And what's also illustrated here is that you can also assess the patient's ability to whether they are responding to treatment, or if there are certain parts of the body where the tumor is located that's not responding. And so by having that sort of information, earlier on, we can prevent the clone, especially the parts that are resistant, from propagating or spreading to other areas. And so by identifying, the areas that are not doing well, we can incorporate or change our treatment plans. And so, for example, we see areas that are not responding well, we can add the additional treatments such as radiation therapy. Or if a patient's not responding well holistically, globally, then that should be a decision for us to add on another agent or to change treatment altogether. So this is kind of the main vision behind why we want to do an early PET-CT type of trial or study. Now, we talked a little bit about response to immunotherapy, but some of the things that we often don't mention too much, especially, are the side effects. And so what I have labeled here are some of the side effect frequencies, particularly the severe side effects that we typically see with immunotherapy. And what we can see here that, especially for the agents like ipilimumab and nivolumab, which are your two immunotherapy drugs, the risk of a severe side effects can be as high as 59%. And again, I'm mentioning severe side effects right here. Now, as Dr. Albertini mentioned, in his presentation earlier, the side effects of immunotherapy, which we often can call immune-related adverse events, can be very severe. When you're lifting the brakes off the immune system to fight cancer, what can also inadvertently happen is your immune system's attacking your normal organs, your normal tissue. And as you know, your immune system is located everywhere from your head to your toes. And so technically, almost any organ, your body, can be affected by immunotherapy. Some of these immunotherapy side effects can result in us as providers having to stop therapy. Some of these side effects can also be permanent. And in some cases, we have to use steroids, which are anti-inflammatory drugs, in order to calm the inflammation that is resulting from the immunotherapy side effect. And in some rare cases, these side effects can be deadly. One of the other advantages by doing the early PET-CT study that we're opening up fairly soon is that we can actually use that early PET-CT to actually assess areas where there might be a little bit of inflammation. So areas that are potentially at high risk of developing a side effect, even before the patient actually manifests with symptoms. And so the PET-CT gives us the ability to kind of look at areas that are a little bit more metabolically active, more inflamed. And so by having some of that information earlier on, one potential future solution that we have is we can potentially, for example, see the areas that are worrisome for developing a side effect, that as a provider, if a patient is doing well with treatment, we can actually use this information where we know they're going to get a side effect, that we can confidently feel comfortable just holding treatment temporarily while we wait for some of that inflammation to calm down. So the early PET-CT is a project that we're developing and has very much promise in terms of the future of being able to help providers like myself to kind of weigh the balance of the risks and the benefits of continuing versus halting treatment even temporarily. Now, some of the limitations that we typically see with imaging like PET-CTs, MRI, and CT is that it can be costly, right? These scans can cost hundreds, if not thousands of dollars. These scans also have the risk of radiation exposure. Patients can have allergies to contrast, and patients can also get kidney injury from these contrasts that are given for imaging. And one of the major things that we find, particularly with the current imaging modalities, is that we really cannot access very, very microscopic or small amounts of tumor. Nevertheless, though, we still use it, and we do continue to use it because it does provide the information that we need to know as oncologists, which is how well they're responding to treatment and assessing the location of the tumors. But the main thing we're looking for nowadays, and there's ongoing studies to do this, which is there a less invasive way? Are there alternative means for us to be able to see how well a patient is responding to therapy? And one potential avenue to do this is actually to do blood sampling, having patients donate their blood so we can actually assess and see, can we find microscopic amounts of disease in the blood and actually detect it? And so, as you know, melanoma and other cancers can spread through the body, through the bloodstream. And so we can take advantage of that fact by actually looking at their blood, identifying cancer tumor cells or circulating tumor cells. We can actually identify things like circulating tumor DNA and actually analyze those samples and actually give us some information to know, for example, how much disease burden or correlate that with disease burden and potentially see how well they do over time as they're getting therapy. Now, this is still an area of ongoing research and is not yet quite standard of care at this point, but you can see that there's a lot of great advantages of this, right? It's accessible. You can get blood draws at any location. Serial sampling is a lot easier rather than doing imaging every few weeks, right? And what's great is that we can detect microscopic disease. And even though at this point, it's still an area of ongoing development, it can one day, as we start to develop the assays even better, can become cost effective as well. Of course, the disadvantage would be for those who are afraid of blood pokes, having to draw blood from you. So here at the University of Wisconsin Carbone Cancer Center, we also have what we call a circulating biomarker core. So we have a variety of scientists who are members of the circulating biomarker core that are working on research for us to develop assays where we can actually detect cancer cells, cancer DNA, and cancer proteins in the blood. And so since the circulating biomarker core was developed, we have over 1,000 patients, samples evaluating all those circulating tumor cells and DNA. And since I've joined the department a couple of years ago, we're starting to analyze stage 4 melanoma patients. And so an example here that I have illustrated on the bottom represents a patient who has cancer or melanoma that has spread to the lung. And so we can assess, for example, at baseline, and which is highlighted red, the circulating tumor cells. And over time, we can assess the number of tumor cells. And so what's illustrated here is in red, that since the patient is progressing, we can see that there's more lung spots, that there's a correlation, with the red dots. And that should be representative, hopefully, of the circulating tumor cells of how well a patient's actually responding to therapy. So this is still an area of ongoing research at this time. Another means and another test that we're also doing as well is the use of circulating tumor DNA with the use of Signatera. So it's a blood-based biomarker test in which the Signatera is made by a company called Natera, for which we're partnering with in order to actually assess circulating tumor DNA in the blood. So how does Signatera work? So what the testing involves is going back to the tissue of the melanoma and actually identifying specific mutations associated with your melanoma. And by doing so, you develop a very personalized test for you. And so by doing so, when you check your blood, you're able to assess, for example, the amount of that specific DNA that was assessed initially on that tissue sample. And so this is an area of ongoing development. And I will say that it is still currently research and not yet quite standard of care. But here at the University of Wisconsin, we are starting to use some of this test to help guide clinicians like myself, for example, in many means. What Signatera has been done initially is assessing the DNA levels before and after surgery, and then monitoring for the DNA levels over time to see if the cancer is returning. What we're now using it for is when the patients actually have stage 4 disease, where they have actual measurable disease. You can assess the baseline and then start trending the levels over time as you're being treated with therapy. So here's an example that I have down here of 2 separate patients. On the bottom left, we have a patient who has a baseline amount of circulating tumor DNA on the bottom left. And then over time, as we started therapy, we noticed that the DNA levels are starting to increase. And so when we finally got the repeat imaging, we're noticing a good correlation with that. And then to the figure on the right, we have a patient who had a baseline amount of circulating tumor DNA. And after starting therapy, their DNA levels went essentially to undetectable levels. And what we can tell so far, when we correlate that with imaging, that there is a good correlation with the DNA levels as well as response. One of the studies that we have available in partnership with Natera is called the Bespoke IO study. And so this is a multi-institutional study involving the use of circulating tumor DNA, specifically with Signatera, to actually evaluate response and correlate that with imaging. And we're also trying to assess whether the ctDNA can actually impact treatment decisions amongst providers. And finally, I want to take an opportunity to kind of discuss a little bit about some of the clinical studies that we have here at the University of Wisconsin. And so you can tell here, this is a bit of a busy slide, but the whole idea behind presenting is that there are many scientists and physicians working tirelessly to find different targets, different means for us to be able to treat melanoma more effectively. And so the development of cancer is extremely complex. And again, this is even a simplified version of it, but there are many ways that we can target pathways, ways to enhance the immune system so we can get patients to respond better to therapy. So, ideally, I'd love it more than an hour to maybe even talk about all the studies that we have available, but I just want to highlight a few of them that I'm excited to have here at the institution. One study in particular is more applicable to patients with stage 4 melanoma who have the disease that has spread to the brain, and specifically melanoma patients that have a BRAF mutation. So what we have, one major study is a randomized phase 2 study where patients with the stage 4 melanoma with a BRAF mutation that has brain metastases, they're randomized to 2 potential groups, one of which they can get Opdivo and Yervoy, or ipilimumab and nivolumab, which is considered a standard of care regimen, or they can be randomized to the other arm where they can get encorafenib and binimetinib, which is another standard of care regimen. But you can also see there that you're adding a third agent, which is an immunotherapy drug, nivolumab. And so the idea behind this particular study is to see, does triplet regimens make more sense to treat this very, very deadly population there? The disease, generally speaking, when metastases go to the brain, usually leads to poor outcomes. And so the overall goal of the study is that we want to see what their response rates are and how long they live when randomized to the 2 options here. Another exciting study that we have open, actually just opened this past week, is this new radioimmunotherapy study. So this is a first-in-human study that we just opened, which is looking at the role of GD2-SADA, which is an antibody drug that binds specifically to GD2, which is heavily expressed by melanoma. But not only just doing that, but that antibody kind of has a second part to it, which allows the binding of the radiation treatment to it. And so this particular study is actually open to many different cancers, but is actually open to melanoma because we know that GD2 is actually heavily expressed in this type of cancer. And so the way this regimen works is, and it's fairly complex, but again, it involves the use of injecting an antibody regimen that specifically goes to the GD2, the melanoma, and then a couple or a few days later, you get a radiation treatment that also gets injected as well. This type of study also incorporates the idea of imaging, so you're able to assess the response to patient fairly early on. And then finally, another exciting study that we have is a bispecific protein molecule study. So this is a first-in-human phase 1/2 study looking at an agent with or without the use of immunotherapy in patients who have an HLA-O201, which is an immune phenotype or a signature that patients have, and occurs in about 50% of the Caucasian population. And this particular study is mainly focusing on cancers that have the HLA-O201 phenotype, but we also include patients with stage 4 melanoma who have exhausted first-line therapy. And so the way the drug works is that it has two components, hence the bispecific component to it, where one part binds to the actual cancer cell and the other that binds to the immune T cells. And so when that engagement occurs, that T cell releases a bunch of chemokines or cytokines, basically toxic things that then work directly onto the cancer cells. And so this type of drug is actually fairly similar to one that just got FDA approved for uveal melanoma. So melanoma that originates in the back of the eye. And so it's very exciting to now actually start seeing this type of agent being used now in the stage 4 skin cancer setting. And so again, I only highlighted just a very few small number of studies, but I'm always excited to say that there's always going to be more studies to come. And so things I want to mention is that, the University of Wisconsin is currently the only NCI designated cancer center here in the state. And we have over 250 clinical trials, and we're continuing to open many more studies, overall with the main goal of finding better therapies for stage 4 cancer, including melanoma. With that, thank you all for listening. And I will have Dr. Albertini come back up.